Thank you, Leslie. That was really interesting. So my name is Georgina Kent. I am a specialist children's community respiratory physiotherapist, working in Torbay in South Devon. So we have a very small service, which is basically designed to keep children with complex needs out of hospital and kind of facilitate discharge. So bringing the kind of principles of chest physiotherapy out of the hospital and to families' homes to try and keep children and young people well and avoid any lengthy hospital admissions. So I am going to kind of talk through a little bit about our service and kind of some interesting bits that have happened in physiotherapy in the last year, and then talk a little bit about postural management and kind of secretion management and a couple of different sort of treatment options. Okay, next slide, please. So where do we start? So prevention is so much better than cure, purely because you're getting people on side. So when someone's in the hospital, obviously it's quite a stressful environment to be in. So if we can work with families and carers and young people to embed that chest physiotherapy routine into their normal daily lives, and that's so much better than trying to do it when they're really unwell and it's quite a stressful environment to be in. So moving on to the next slide, please. So there's been a lot of work in the last year, 18 months, and this area is becoming a real hot topic. So I've got a few infographics here from a study by Nuala Gibson et al., which I think was 2021. And it's just really nicely laid out. So it's all about kind of this MDT approach, like Leslie was saying. So working together with medics, with speech and language, with physio, to try and have a holistic approach to chest health. So we're looking at sort of risk factors for someone who is more vulnerable for chest infections. So like your dysphagia, your frequent respiratory symptoms, seizures, snoring at night time, reflux, having someone who is wheelchair dependent and who's had lots of hospital admissions as well. And then looking at our general kind of preventative strategies that Leslie mentioned earlier. So good personal hygiene, especially dental hygiene, optimizing nutrition, vaccinating against influenza as well, and encouraging that physical activity. Next slide, please. So then we kind of come on to our assessment. So we're looking at kind of history, any concerns, any previous admissions, the sort of history of their respiratory symptoms, having a physical examination, so looking at their breathing pattern, any signs of kind of respiratory distress, looking at their observations, oxygen saturation level, respiratory rate, heart rate, what their chest wall looks like, especially in this group, if there's any scoliosis, listening to their chest as well. And then obviously, like along with sort of speech and language colleagues, looking at assessment of eating and drinking and how they manage their secretions. And obviously this can be very different. So when someone's well, they can be getting along fine, but they only need to be knocked off slightly to be in a real pickle. And then we've got lots of diagnostic tests that we can do to kind of give us even more information. So things like x-rays, CTs, sleep studies overnight as well, and video fluoroscopy. Sputum culture is something that we regularly do within paediatrics, just to make sure that the antibiotics that we're giving these children are actually working. So that's something that we do quite regularly, and I really recommend, you know, whenever a child goes into hospital or young person, that they get a sputum sample. So next slide, please. So here we're coming on to the treatment. So from a physio perspective, we will assess and look at cough. I drive our hospital physios mad because I say that basically as a physio, if we are someone's cough, it's the most important thing. So thinking about, is it effective? What does it sound like? Is it wet? Is it dry? Like, we have 3 phases of our cough. So we have an inhalation phase, a glottic closure, and then an expiratory phase. So where is the problem there? Is it that that person can't take a big breath in, or do they struggle to get the air out? Because that will inform my kind of treatment planning. Then we'll hopefully give them some airway clearance or suction and have a bit of a chest plan, and our role is to prescribe that, but also educate the parent, the family and the carers and the young person, and then monitor that to make sure that it's still working and they're still keeping well. Next slide, please. So this is just a little bit of work that I've been doing as part of my role on the APCP, which is the Association of Paediatric Chartered Physiotherapists, so on the respiratory committee. So I think I've just seen it in the chat that Leslie's saying they've got a screening tool and full assessment similar to what we've done. So basically, as a result of lots of hard work and looking into lots and lots of different studies, the APCP have created a risk identification matrix, which helps to look at who is at risk of getting a chest infection, and these are the kind of actions that you can take to help with that, which is really, really helpful. They've also released a document to help support with getting a service and with getting business cases and giving you an idea of what to do to hopefully be able to then create a service. So there are not that many children's community respiratory physio services, and I think there are probably even less adult PMLD, kind of LD respiratory specialist community services, because that's something that I'm definitely finding is it's fine for me now, but I then need someone to transition them to, and at the moment there isn't that service up and available. So although this is very children's focused, the same principles would apply to adults with LD as well, and it's a really useful document, so have a little look at that. Next slide, please. So moving on to kind of some of the things that we will do. So postural management is a huge part of what we do in a kind of respiratory physio setting, but also obviously is something that hopefully a lot of the LD physios on the call are happy doing. So in our area, we do an annual assessment of posture, and we use the Oxford Postural Management Assessment. So what that does is we look at the posture in seating, hopefully in their specialist seating, and we will look at weight distribution to make sure that there's the body is well supported, and then we will hoist them, or they can transfer onto the plinth, and we'll look at their range of movement there. And what we're looking is to make sure that they are achieving these specific ranges of movement, which means they are able to sit comfortably, able to stand comfortably, and therefore their specialist equipment is actually working for them. Because really we want to maintain that being able to sit and that ability to stand, because that is imperative for chest health too. It also then allows us to kind of monitor scoliosis and hopefully make quite timely referrals to the spinal team so that they can give their advice. Next slide, please. So then coming on to kind of the more secretion management side of things. So we touched on it briefly, but what we would do is we will assess someone's respiratory health, looking at their cough, looking at their breathing pattern, listening to their chest and doing a full history. We'll then create a problem list, kind of where things are a bit tricky. Is it that they can't take that big breath in, or is it they've got really sticky secretions that they struggle to get up? And create basically a chest management plan which is individualized for that particular person. We'll then do carer training to support the carers to be able to carry out that chest management plan, because sometimes it might involve more complex things such as cough assist or the vest, or deep suction, oropharyngeal, nasopharyngeal. So we'll support the carers with those learning needs. And then thinking about kind of escalations. So with some of our more complex cases, we have a plan for when they are well, and then a plan for when they are unwell, and they can then move between the two. Okay, next slide, please. So one of the really simple, nice, basic kind of things after, so if you're doing for your chest physiotherapy, is what we call PEP. So we have it's positive expiratory pressure. So it works by providing a bit of resistance, making it harder to breathe out. Sometimes we have what's called oscillatory PEP. So the aerobica, that little white device at the end, is what we would call an oscillatory PEP device. And that's just because it creates some little vibrations, which helps to move the mucus. But essentially, the principles of PEP are that it helps to bring air behind the secretions, move the secretions from the sort of lung and chest walls, and then it helps to splint open the airway so that you've got secretions moving and you've got nice open airways to kind of get it out. But it's not going to help necessarily so much with your cough. Then at the end, we've got bubble PEP, which is your really, really cheap and easy thing to set up. So it's just a bottle of water with some suction tubing. And then in the middle, we've got a PEP mask here. So we're monitoring the pressure to make sure we're getting nice, splinted, wide open airways. Okay, next slide, please. Okay, and then so then we're coming on to manual techniques, which is probably the thing that most people associate with chest physiotherapy. So usually it's that percussion just on the chest wall. And again, the idea behind that is moving secretions into sort of central airways to help bring them up. Then you also have like VIBs, so where you might shake and help if someone's struggling with that expiratory force of that cough, you might do some shakes on the chest to help bring stuff up a little bit more. These are great, I would say, with children and smaller people because you need quite a lot of force behind it. But also when we're getting into sort of like older teenagers, young adults, if you've got really complex chest wall deformities and scoliosis, it's actually quite difficult to do decent manual techniques because you're not sure where that lung is if you've got a really nasty scoliosis. So yeah, just that's something to bear in mind. Next slide, please. Okay, so coming on to the more advanced high-tech stuff. So we've got the high frequency chest wall oscillation vest. So this was kind of designed in mind originally with patients with cystic fibrosis. So that was kind of the manufacturer's main target market. But actually it wasn't seen to be more effective than the sort of much less expensive devices for people with cystic fibrosis. So they kind of started to sort of branch out and started looking at the sort of PMLD population. So what the vest does is it inflates and then it shakes. So it kind of does a sort of automatic percussion. You can also get it with a wrap rather than a sort of life jacket shape, which makes it easy to get on and off. And so, yeah, so it's great for moving secretions into those central airways, but then you still need a way of getting them out. The vest, there's a couple of different manufacturers. The cheapest is around, I think, around £4,000. So it is an expensive piece of kit. However, if you think how much a hospital admission costs, you know, actually sometimes it's quite easy to justify it. And you have, yeah, it's so you can get single patient use ones, or you can get like a reusable one, which we would use with our community patients. Next slide, please. And then the cough assist. So it's mechanical insufflation exsufflation. So what this machine does is it works on the cough, so it helps with that weak cough. So it gives you a bigger breath in and then a negative pressure, so it sucks the air out. So it helps to really bring those secretions up higher so that they can be like coughed and cleared, or maybe like using a yanker rather than using your more deep suction. So generally with the cough assist, in the past, we used to use it a lot with people with neuromuscular diseases. However, it does work well with our sort of PMLD cohort as well. It's just not quite as effective if they can't always follow the sort of the pattern of the machine. So you can set it up to do like an automatic mode where the machine just does what it wants, or you can set it up to have a patient trigger so that it's a bit more comfortable for the patient. These are around about £5,000 as well. Okay, next slide, please. Okay, so I've got a few little bits of reading on there. So some of the studies that I mentioned, and again, that risk identification matrix is really, really a useful tool. And yeah, thank you. I think it was Dr. Sharma as well. Like, we're really, really passionate about trying to get community paediatric respiratory physios. It's so difficult to get funding, and we've had lots of business cases going in, and then we're in a fortunate position now where we do have a service, but we have got children that are surviving well into adulthood now that we need to find a home for when we transition them. So yes, I'm really hoping that they will start to fund the community, the paediatric side better, but also having that realization that we need somewhere for these children to go afterwards. So yeah, thank you very much. I will hand you back over to Alison.